Oh, you're on mute, Laura.
Oh, that'll make things different, won't it? Hello, everybody. Welcome to the community table with Priscilla Easterling from Kentucky Voices for Health. And she's going to talk to us today about mainstream resources and share her expertise and her wealth of knowledge with us, and hopefully give us some good insights and tips and tricks on all of this. And I know there are a lot of questions because there's a lot going on with mainstream services these days. So I will turn it over to you, Priscilla, and let you do your thing.
Awesome. Thank you so much. Hi, everyone. I'm Priscilla Easterling. I'm the Director of Outreach and Enrollment for Kentucky Voices for Health. I'm going to go ahead and share my screen if that's cool. Give me just 1 second so I can pull up my slides. Um, okay, here we go. Oops. Technically should have. Uh, Computer's doing the computer thing. Okay, just one more second. All right. So please let me know if you don't see this, but we are just going to dive in. Um, all right. So I am very happy to join y'all today to talk about mainstream benefits. Really, we're going to talk a lot about healthcare. As I said, I'm with Kentucky Voices for Health, and we are a nonprofit, statewide, nonprofit, nonpartisan coalition of consumer health advocates. We primarily focus on healthcare, but we do tangentially talk about a lot of other benefits and programs. I am a trained connector, and so I work with the Connect system. And so I like to do a lot of education about all of the resources that are available through Connect resources, and connectors as well. So that is going to be the focus. Um, there is a lot of content that I am going to try and get through today, but please don't hesitate to drop a question in the chat or come off mute. I am happy to answer any questions as we're going through if you have something that pops up. But I will also make sure to save some time at the end for questions. But don't hesitate. Feel free to just pop in and I can address it at the time so that you don't forget a question. But so that's a little bit about KVH and a little bit about me. A lot of our work has been really focused on Medicaid defense and ACA defense with the one big beautiful bill, which I am exclusively referring to as HR1 from now on, because it's really a terrible bill that really undermines so many of these really critical benefits and safety net resources that Kentuckians need to access to be able to live healthy lives. So there's a lot that changed in that bill, a lot that's coming down the pipeline, and so I want to make sure that folks know that there are folks who are involved in advocacy around this. If you're interested in getting involved, we do have a Medicaid Defense Coalition. It's getting ready to pivot to being like the Keeping Kentucky Covered Coalition. We love alliteration. So if you're interested in getting involved in any of that, if you want more information, if you want to attend our meetings, we've switched to a monthly cadence. And our next meeting is actually today at 2 p.m. So they're all virtual, always a Wednesday afternoon. If you're interested in getting involved, you can complete that survey. And I'll share these slides with Laura afterwards. So you can just click that link, fill out the survey, and then we can reach out to you or my colleague Morgan Whiting. She's our outreach coordinator. She'll reach out to you directly and get you plugged in. So all right. So when we talk about health insurance, first of all, I love to give the big picture and sort of let people set our expectations and that sort of grounding. Where are we in Kentucky right now before all of the impacts of this bill kick in? So for Kentucky, there are about 4.4 million Kentuckians. And the really great news, at least on the health insurance side, is that the absolute vast majority of Kentuckians do have some sort of health insurance, health coverage. Um, are they covered by something? So looking at that, that's about 4.18 million Kentuckians who do have some sort of health insurance. Most of those folks get their insurance either through public insurance or private insurance. Private insurance is a little bit higher, but when we're talking about public, that's going to be your Medicaid, Medicare, and then TRICARE. That other public is TRICARE, VA benefits, and other benefits like that. When we talk about private insurance, those are your employer-sponsored plans. Connect resources, Connect also, Connect ACA coverage also falls under that category. And then there are just individual plans that are available off marketplace. The sad news is that we still have about 250,000 Kentuckians who are currently uninsured. And with HR1 passing, we do expect that to increase quite a lot, if not double, more than double. So for our current Medicaid enrollees, so going back 1.55 million, that's dropped a little bit with the unwinding of the last 2 years during the public health emergency. Folks were able to get enrolled in Medicaid and stay enrolled in Medicaid regardless of changes to their income or changes to their household situation. But back in 2023, the entire adult population had to go through a redetermination. The rules sort of reversed to pre-pandemic rules. And so the entire adult population went back through a redetermination. And now we're hovering around 1.3, 1.4 million. It kind of oscillates because there's constantly case activity. There are constantly changes. Medicaid is open for enrollment year round. And so every day new people are applying and new people are also disenrolling. You know, they get a job offer that offers insurance. They get married, they change to a spouse's plan. There are lots of reasons, but that number sort of oscillates from month to month. But we are hovering around 1.4-ish million right now, and about 1 in 3 Kentuckians are currently enrolled in Medicaid. Okay, so just to sort of, again, set the stage, before we talk about HR1, children and expansion adults do represent more than half of all rural Medicaid enrollees. And so if we're looking at this breakdown, about 36% of rural Medicaid enrollees are children, which is just such a big deal. About 20% are adults. And I'm focusing on the expansion population because this is the group that would have been newly eligible for Medicaid after the ACA passed and after Medicaid expansion passed back in 2013. These are the folks who are not in one of those traditional categories, is what they call it, which is age, blind, disabled, or over 65. These are the folks who make 138% of the federal poverty line or less. They have some income usually, but they just don't have an offer of affordable health coverage, and they don't make enough to be able to afford a plan on the marketplace through Connect. So the expansion adults are the primary targets of the HR1 bill. A lot of the provisions that were passed in that are specifically targeting these expansion adults. So this is just, again, setting the stage for what we're about to talk about. So thinking about those uninsured Kentuckians, a little over 250,000. What surprised me, there are a couple of things here that really surprised me, and this comes from a ACS American Community Survey that was gathered by CMS, the Centers for Medicaid and Medicare Services, that sort of runs Medicaid and ACA and all of that. Of the 257,000 Kentuckians, most are employed. At least 200,000 have a household member with a full-time job, but that job just does not offer affordable coverage or any coverage at all. A lot of folks are already eligible for some sort of federally subsidized plan, whether that's Medicaid or marketplace coverage. Marketplace is also the ACA, it's also Connect. They're all very intricately tied. So if you hear one term, that's what we're talking about. Marketplace, ACA, Qualified Health Plan, Connect, all of those plans are going to be the same. And the majority of folks are already eligible for some form of federally subsidized plan, but they just don't know it. About 110,000 would be are Medicaid eligible, but don't know it, or lost their coverage, tried to enroll, but because of paperwork issues, they were unable to complete that enrollment, or they went through the redetermination process and were terminated because they did not submit documents, but they're still eligible. They're just not actively enrolled. And then almost a third are ACA eligible, about 82,000, which I think is a lot of times with ACA specifically. Maybe folks have shopped before. They went and looked at coverage back in 2019 and it was really unaffordable, or it was going to cost a little bit more than what they could safely budget for. But a lot has changed with the ACA between 2019 and now, and a lot is going to start changing at the end of this year, beginning 2026. And then the other really important note for me is that 150,000 of the folks do not have internet. 70,000 do not have cell phones. And so when we think about access and trying to get people connected to coverage, there are a lot of times the way that the state that connectors that folks advertise is going to be through the internet. There are, ads on your social media, there's ads, there are emails that go out, there are, like banner ads that people put on the website, and they take for granted that anybody could just pick up their cell phone, go to plug and connect into their cell phone browser, and go and enroll in coverage through their phone on their own, and that's just not the case. A lot of people have issues navigating that system, even with cell phones and with internet and all of that. But for the folks who don't have internet, the main way to be able to get those services is to reach out, is to either call the call center, go in person to DCBS offices, or to work with a connector who can handle all of that for you. And for the folks who do not have a cell phone, that's going to be, again, going in person, working with a connector, and hopefully finding someone who's able to meet you in person so that you're able to navigate that system. So, and then the other just really important, some families are SNAP recipients. So they are in the Connect system. They are currently receiving SNAP benefits, but they are uninsured. They have not enrolled in some coverage. And for most SNAP recipients, they're likely eligible for Medicaid, but there are some SNAP recipients who are also eligible for marketplace coverage and maybe chose not to enroll. Maybe they don't know it. They only applied for the one program and didn't consider applying for health coverage. There are lots of reasons why that happens, but it's really important to know that most SNAP recipients are likely eligible for some sort of federally subsidized health insurance. So it does not have to be as unaffordable as they might imagine. So now getting into the details. So for HR 1, there were two versions, the House version and the Senate version. The House ended up just passing what the Senate the Senate's version, and sort of just trying to get it passed before the 4th of July. It was very political. It absolutely passed along partisan lines, and it was a rush job. It very much was. So because of that, because of the provisions in that bill, right now, KFF, the Kaiser Family Foundation, They currently estimate, and there are lots of different estimates that are around between 190,000 to 400,000. I'm going with that very conservative middle of the road, that I can do the math and figure out like how they got there. They're estimated about 250,000 Kentuckians are estimated to lose their Medicaid or marketplace coverage. And that's about 190,000 that would be losing their Medicaid, and about 47,000 who would be losing their marketplace coverage. It's roughly around there. um, a lot of what the bill did was shift the cost directly to the state. So right now, Medicaid is a federally matching program. So for every excuse me, for every around 72 cents it changes from year to year, but around 72 cents for every dollar of Medicaid that is spent, about 72 cents comes from the feds and the other 28 cents comes from the state. This bill really shifts that cost over time, so that more and more of that cost goes directly to the state. So with that sort of shifting of the financial mechanism, about 1.7 billion, the Kentucky State General Fund will get about 1.7 billion less for Medicaid yearly. It will also mean that about rural healthcare providers will lose about 12.3 billion over 10 years. And over 20,000 jobs will be lost. That's a very conservative estimate, and that is thinking about not just there was a study that was done um, back in, I want to say it was May or June. And the estimates were that about 35 of Kentucky's rural hospitals are at risk with this bill passing. And so thinking about those rural hospitals, they bring not just those healthcare jobs, but all of the other incidentals coincidental jobs, that's not the word I want to use, but all of the other jobs in an area that come when a hospital is there. It's not just your medical professionals, it's also the aides, it's also housekeeping, it's also food service, all of those different services that a hospital needs to run. Plus, oftentimes with a hospital, there are lots of businesses that pop up around it. And so when those hospitals close, providers will then move to population centers because that's where the closest hospital will be. That's where they'll be able to get their funding. That means that not only that economic center in rural communities will be gone, but then all of those other collateral businesses that popped up around that, they will suddenly not have that same population, that traffic of people coming into the hospital. And so a lot of collateral consequences that go into the loss of hospitals and folks needing to travel. That's not even to talk about the burden that puts on individuals who now will go from a hospital being 20 minutes, 30 minutes up the road to then having to travel a county over, 2 counties over, and what that might look like. So one of the things the Senate also included was a 50 billion rural transformation fund to try and offset some of the loss of federal funding for rural hospitals. But again, it is a drop in the bucket. It's 50 billion that is spread out over 50 states. It is not 50 billion for Kentucky. It is 50 billion spread out over states, and that's $1 billion, which is still less than what Medicaid brings in every year. So it's gonna get real rough out there. So most of the Medicaid provisions don't go into effect or do not go into effect until October 2026. And that was very intentional. Very intentional to try and make feel that until after midterm elections. They're not quiet about it. That's the exact reason why they did this, why they've timed it this way. And so with that, the most of the implementation for Medicaid provisions, again, October 2026. So this time next year, we'll be talking about what this looks like in real time. Beginning October, this is what this will look like. But for now, we're still about a year out, so we still have time to mitigate some harm, to do some advocacy. We're still looking for lots of guidance from the federal government about what's going to be expected, about how this has to be implemented, and then working with the state to do as much harm mitigation during the implementation phase as possible. Because here's the rules, here's a set guideline of rules, but you can still be very intentional and be smart about trying to make it better or worse. What are some systems, what are some processes that we can make it easier for folks to have to comply with this? And what are systems where it would be harder? And with all of the provisions that are passed, so much of it relies on increased paperwork for individuals. It really shifts to just requiring a lot more documentation for individuals to fill out. And that is where I'm the most concerned about how it's going to impact individuals. So the two that are going to go into effect at the end of 2026, the work reporting requirement, excuse me, the work reporting requirements and 6-month eligibility determinations. So work reporting requirements, we'll talk about this in a minute, but that is going to specifically focus on the expansion, adults, and we've already seen the work reporting requirements implemented for SNAP. And with SNAP, we often hear stories about people just struggling to report their work. It's hard to submit. They get tripped up. They have to do it a number of times. And it's easy to get lost in that. And the same with that 6-month eligibility determinations. Currently for Medicaid, we are on an annual renewal. And so most folks, once a year at best, they have to submit their documentation just of like their work, their household situation, their income, what does their household income still look like? Are they still eligible? And the great thing about Kentucky right now is that we have a very high ex parte rate. And so they're really what that means is that they're able to passively renew a lot of adults and a lot of adults back into Medicaid. So if your income has not changed year to year, if you're filing taxes and the IRS, like from year to year, it still says the same thing and you're reporting the same thing on your income, the state can just passively say, okay, great, we checked you, you're good, you're enrolled for another 12 months. The problem comes when anything in your household has changed, including, and very tailored for this group, where you're housing and where you are living. We've heard a lot of issues with folks in the last 2 years since redetermination started again for Medicaid, folks not getting their notices, of the notices going to an old address, and then the person does not submit the paperwork because they didn't get the notice, and then they're terminated not because they're not eligible for Medicaid, but because they did not fill out that paperwork and turn it in. But they didn't fill it out and turn it in because they didn't receive the notice asking for it. So there's a lot of ways to get tripped up. But even when folks do submit their paperwork, submit that documentation that they ask for, there are also times where that just gets lost in the system. or it's not enough. And then the state has to reach back out to an individual and ask for additional. Say they asked for 3 months of pay stubs and a person submitted one, then the state has to reach back out to the individual. But if they don't have a stable housing situation, if they don't have a cell phone, if they don't have internet, how are they getting that notice that the state needs more? They're often not, and then they get terminated for not filling out, for not sending in the additional paperwork. So let's move forward. So talking a little bit more in detail. So those work reporting requirements that I was talking about, my mouse is being so weird right now. Sorry about that. Okay. So for the work reporting requirements, the minimum requirement would be that individuals have to verify that they're working or participating in sort of work-related activities like looking for jobs, looking at doing volunteer work, caregiving. That should all fall into that category of approved work-related activities. But we'll know more as the state actually moves towards implementing this work requirement. But they have to report work-related activities for at least 80 hours per month, and they'll have to do it at application and renewal. So think about those work reporting requirements. One of the details is like you have to have worked for 30 days before applying for Medicaid. That's problematic for lots of reasons. But thinking about just that process, that's additional documentation that you have to provide just to apply for Medicaid. And if you get approved, great, but then you'll have to do a renewal 6 months later, and you'll have to prove that same information all over again. And once that gets approved, you'll have to do that all over again in another 6 months. And so it's just adding a lot of paperwork, a lot of process to eligibility that is likely not changing. Those folks are not any less eligible for Medicaid in that 6 month period. It's just adding a paperwork burden to them and to the state. They have to then process all of that paperwork, and really thinking about, even now, there are so many times where the call center is completely bogged down. If you've ever called the DCBS call center, I am certain that you've had or you've heard of someone staying on hold for an hour or 2 or 3, or getting disconnected, never reaching somebody. And so thinking again about folks who do not have internet, who don't have cell phones, how are they able to stay on the call line for an hour just hoping to get through to somebody? One of my clients that I work with, they just didn't have enough minutes on their phone to be able to make that call and stay on the line. And so there are lots and lots of barriers that are coming with this, that could just lead to people losing their coverage. Again, not because they're not eligible. It's just added bureaucracy to prevent eligible people from getting enrolled. Even if they meet all of the requirements. One of the things that we hear people talk about in this bill is, well, people could still qualify for an exemption from this mandatory work reporting requirement. And that's technically true. There are exemptions built in that folks could, if they're caretaking, if they're in school full time, they would be able to get out of having to do this mandatory work reporting if they're disabled. But also think about, what does it take to qualify for an exemption? Because it's not going to be a straightforward box check like, oh, yes, I am disabled, or yes, I am in school full time. You're going to have to verify that information as well. And disability is particularly difficult because it's up to the state to determine what is the definition of a disability. If they're using the Social Security definition, qualifying for Social Security disability is famously hard. It's famously hard. Most folks are denied Social Security disability twice before they're able to get approved for it. And it often takes more than 24 months. So for that 24 months that it takes you to get qualified qualified for Social Security disability, just to be able to then say, here's a paperwork saying, yes, I am disabled and I qualify for Medicaid. Again, adding more bureaucracy to that process. And if they don't use, if it's not Social Security disability, but you're, working with a provider, how are you going to see your provider? How are you paying to see the doctor to get that disability diagnosis if you're not currently insured? So lots of barriers here that are really just genuinely, I'm very concerned that folks are going to get tripped up in this process, because I know they currently are, and the system does not have these extra barriers. With these extra barriers, I just see it getting much worse. So one of the other things, mandatory copays. There's a requirement for states to impose copays of up to $35 for many health services, excluding sort of basic preventative care and drugs. So your vaccinations, like well visits. But if you're sick for anything, there would be a copay. And adults with income above 100%. So that between 100% and 138% of the federal poverty line, again, that's that expansion population that I was talking about. There would be those mandatory copays, and it can't be more than 10% of your household income. But Kentucky used to have copays, and they were as low as $1 and $2 and $3 copays. But we heard regularly that even $1 copays prevented people from going to the doctor because they did not have that, let alone $35. That's a water bill, right? Like that is the $35 is going to prevent somebody from being able to go to the doctor. And any sort of delay in treatment, any delay in seeking treatment can often make that injury or make that condition much worse. Any delay often leads to it becoming a much more expensive thing to treat after that. So start off with a cold, and a cold is not a good example, but you start off with like a sinus infection, but that can absolutely blow up into something more. I had pneumonia 3 years ago. That started off as just a very minor thing that I just didn't have time to go to the doctor. I'm like, it'll be fine. It'll be okay. But then I woke up one day and boom, it was a big deal. And I had to go to urgent care and I had to go to the hospital. And if I didn't have insurance, that would have been way more expensive for me. That just very realistically, going to the emergency room is an expensive service. And so I think that's, again, a thing that we need to keep in mind. Copays, whether it's $1, whether it's $35, all of that can prevent somebody from seeking the treatment that they need, and that can be a much more costly decision later on. So the double redetermination periods, we already talked about that. More that every 6 months instead of yearly. Yeah, it's it's just additional paperwork for no reason. Most people, their eligibility is not going to change every 6 months. And if it does, they can report that change, but it should not be required of the entire population. That's just, again, adding more burden to individuals and to the state for no real reason. The ban on provider taxes, we're not going to really talk too much about that. But one of the ways that the state could have offset the loss in federal funding would have been to increase or add new provider taxes for providers who provide Medicaid services. And it's just like a key funding tool for Medicaid programs. But HR 1 banned that from happening. They did not want states to be able to offset those costs at all. They want the state to have to absorb it because the goal is to hopefully um, reduce the number of people who are enrolled in Medicaid. It doesn't mean those folks are not eligible for Medicaid. It's more about preventing, it's more about undermining the program and enrollment in the program. And so they banned new and increased provider taxes, and it really restricts states' ability to respond to local health needs and priorities, which puts additional pressure on Medicaid budgets. So other measures that would increase hardship that we'll talk about, they're also a ban on gender affirming care for youth. The HR1 prohibits Medicaid from covering gender affirming care for children, limiting access to medically necessary services. And there's a nursing home staffing rule moratorium that places a hold on enforcing the nursing home staffing rule. Which really was about making sure that there were more nursing, that there's more staff available in nursing homes because they saw that there were better outcomes when there were more staff physically in the building of nursing homes. And that was supposed to go into effect this end of this year. But now there's a 10-year moratorium on that. So it won't go into effect for another 10 years, which is, again, undermines care quality and safety for Medicaid recipients and for everyone else in a nursing home. So overall, these provisions will create significant barriers to care and reduce protections for vulnerable Medicaid populations. All right, and so the other side of this on the healthcare side is the ACA marketplace. So most of those, well, the first two go into effect at the end of this year. Technically, three big provisions for ACA go into effect at the end of this year. So special enrollment periods for January, there is and it's splitting. But for beginning January, there is currently a low income special enrollment period. So for folks who have income at 150% of the federal poverty line or below, usually between that 138% and 150%. So just above Medicaid eligibility, up to 150%. There's currently a special enrollment period that lets those folks enroll in ACA coverage anytime throughout the year. They can qualify for a special enrollment period at any time throughout the year. And let me back up just a second. For Medicaid, it is open enrollment year round. You can apply and enroll any day of the year. But for ACA marketplace coverage, that typically it only has a open enrollment period that's November 1 through January 15th. And then outside of that, you have to qualify for a special enrollment period to be able to get enrolled in a plan outside of open enrollment. And so for folks who are in that 150% or below the 150% of the federal poverty line, or below, they're currently able to get enrolled year round through the special enrollment period, but the HR1 removes that special enrollment period and limits them to only being able to get enrolled during open enrollment. Now, this is kind of a big deal. A lot of folks have been able to take advantage of it. And it's really for folks who yes, income, but they're often churning back and forth between Medicaid eligibility and marketplace eligibility, or they're in lower income jobs that offer insurance, don't offer insurance. And there's a lot of just like switching, fluctuating income. And so that special enrollment period was supposed to really provide an extra safety net for folks so that they're able to get enrolled in healthcare throughout the year. Again, this HR1 removes that. There's also, it changes the eligibility for lawfully present immigrants. And so currently for folks who, for lawfully present immigrants who would be subject to the 5-year bar, who would otherwise be eligible for Medicaid, but for their immigration status, They're currently able to get enrolled in the ACA marketplace through Connect. They're able to do that and get premium tax credits. And those premium tax credits on the ACA marketplace are the piece that make ACA marketplace coverage affordable. It's a subsidy that goes directly to your insurer, and all folks enrolled in this coverage have to do is, um, you know, pay the bill that they get from their insurer. Um, oh goodness, oh, my computer just frizzled, but okay. It's a weird thing. Sorry, y'all. So folks are able to get enrolled in coverage and get those premium tax credits, even though if they would, sorry, they would still be eligible to get enrolled in premium tax credits and marketplace coverage. With their income under 100% of the federal poverty line. That rule is also eliminated beginning January 1. So there are folks who would otherwise, if not for their immigration status, they'd be eligible for Medicaid. And so they're able to go through the ACA right now. But again, that's changing at the end of this year. It also eliminates eligibility for refugees, asylees, and people with temporary protected status beginning January 1, 2027. And so these are all folks who are able to get coverage through the marketplace today and will be able to for all of 2026, but beginning for 2027, they will no longer be able to get enrolled in marketplace coverage. Okay, and then the last big change for ACA is that the enhanced premium tax credit. So I was just talking about these subsidies. Back in 2021, the Biden-Harris administration helped pass the American Rescue Plan Act, and that included an enhancement to those premium tax credits to help make ACA coverage even more affordable for families and individuals. That was extended again in the Inflation Reduction Act back in August 2022. And so at the end of this year, it was extended to December 2025. And this year, December is when it is supposed to expire. And there has so far been no action, no conversation, no talking in Congress about extending these tax credits and that enhanced piece. So the premium tax credits would still stay around. The APTCs, advanced premium tax credits, are still staying around, but they would revert back to the pre-2021 rules, which are just a bit less generous. It also removes that 400% income cap would be reinstated. So right now, folks with income over 400% are able to get premium tax credits, but that would be reinstated. And so overall, we're looking at ACA marketplace plans going up around 18%. The premium tax credit will cover a lot of the difference for folks, but individuals and families will certainly feel that price increase when they're shopping for coverage beginning in November. So it's also a big deal. There's still room, there's still time for advocacy, for them to change their mind, for them to pass something. But we're not necessarily optimistic. So again, back to our friends at Kaiser Family Foundation. This is about, again, that rural health fund. 50% would have to be distributed among states with approved applications. It only covers about a third of the estimated loss. Rural Kentucky is projected to lose about $12.3 billion over 10 years. The temporary, a lot of the big losses would be for fiscal year 2026 and moving forward to 2030. And then 2/3 of the reduction in funding will occur after 2030. Again, it's just not going to cover the loss that we're looking at with the shifting of reducing federal funds and increasing the state's cost share. So, and UK did, they have put together a really great website. And then they've announced it's linked here as well, that they have a website that's going to be devoted to monitoring all the federal government activities and will include summaries of all of these issues. So that's a great resource if you'd like some more information, and they'll communicate any important updates as well. So if you'd like more information, if you want a good place to track it, that's a great website to check out. So, and with all of that in mind, let's talk a little bit more about how to keep Kentucky covered. And so let's start with connectors. As I mentioned at the top of this, I am a trained connector. I was a navigator, which is basically the federal version of a connector in Virginia for 4 years before I came to Kentucky. And I've been doing this here for about 5 years now, which is also crazy to say. There are 3 contracted agencies that have connectors, and so there are connectors available for free in all 120 counties. We're talking about Louisville. There are literally 15 to 20 connectors in Louisville, but connectors from anywhere in the state can help anyone anywhere in the state. So if you know friends, family, anybody who needs help, needs to get connected, there is a connector somewhere in their neighborhood, promise. The best way to reach out is, of course, you can call the Connect call center, but I've also included the direct contact information for the 3 contracted agencies. You don't have to be a part of the contracted agency to be a connector, myself included. There are lots of other agencies that also just have a designated person as their connector, and have been approved by the Kentucky Health Benefit Exchange to provide the service. So the basics, connectors help Kentuckians find health insurance. They assist with health coverage, and the application process. They're able to help with redeterminations, submit paperwork, track notices, reach out to individuals, and really do that caseworking piece of things. They're also able to create referrals for resources. Connectors, they can help apply for the following benefits: Medicaid and KI-HIP. We're not going to talk about KI-HIP. 90% of people are not eligible for that. But Medicaid, they can apply for the ACA marketplace coverage, or QHP, a qualified health plan, with or without that premium tax credit. Most people apply for the premium tax credit because, again, it's a thing that makes coverage affordable. They can also apply for SNAP or CCAP. And up until like literally the end of this month, KHB had allowed for the connectors to be sort of separated. So there could be health connectors and then other program connectors. So health connectors primarily focused on Medicaid and APTC, Medicaid and ACA marketplace coverage, while other program connectors focused on SNAP and CCAP. But with the new training that's coming out in September, they are fully integrating those 2 things so that all connectors all over the state are trained to be able to help with all of the programs that are available on Connect. That's really great because it really ensures that sort of one-stop shop. You can work with a connector who can help you apply for all of the programs and benefits that are available on Connect. So that's a great move. Very excited about that. And the state is currently working on integrating WIC into the Connect system. It has been federally approved, but it's going to take about a year to 18 months to really build it into the Connect system. So we're probably looking at somewhere closer to next summer that it's in there. But we keep tracking it. Connectors can also help report changes in information. So if you move, if you change jobs, if you get married, divorced, death in your family, income changes, they're able to go into the system and report all of those changes for you or for individuals, so that you don't have to do that to yourself. This is incredibly important, again, for that group of folks that we talked about, with 150,000 who don't have internet, 70,000 who don't have cell phones. Connectors are an incredible resource who are able to take care of all of that for individuals and families. So don't sleep on connectors. They're great and they're free and they love to do this work. They're here because they like to help people and want to be able to connect folks to the services that they need. They're also able to help with that recertification of benefits. So, when the state sends out a notice saying, hey, we need this, your income looks like it's different. Can you submit 3 months of pay stubs? The connector can get that notice, read that notice, reach out to the client, get the paperwork from the client, tell the client directly exactly what they need, get that paperwork, and then upload it into the system themselves directly so that it's not on the client to take care of all of that. There's also, again, they're available in all 120 counties. The search for connectors by county or name on connect.ky.gov. And you can also filter for language, type of program, public, or facility-based. Just a quick note, connectors all agree to act in the best interest of the residents. So they have to provide fair and unbiased information to anyone who's seeking application for assistance. Their job is just to help fill out that paperwork, get someone enrolled for the benefits that they're eligible for, upload any of the additional paperwork that's required, and really do that case management piece again, and help with any troubleshooting. So if someone does run into a problem trying to go through the process, they submitted documents or they're lost because they submitted an application, but it says that they're not eligible and they feel really confident that they're eligible. A connector is really able to help troubleshoot all of that. And then they're able to track and submit any issues that come up. So they can work directly with KHBE. KHBE can look into a case and individually fix cases. And so again, that's why it's super important to know who your connectors are to make those relationships. They're an incredible resource that's available. Again, you can find them on connect.ky.gov. You can search for them. If you know somebody's name, you can search by name, but mostly you can just search by county, and that's really helpful as well. And here are just some of the filters of what it looks like. And you can search by language. Connectors all self-report what languages they speak. So if you're looking for someone who has a specific language need, you're able to do that. And then you can also search for, availability, time of the day, if some connectors are available before 9 a.m. or after 6 p.m. So you're also able to filter out for that. So, okay. With that in mind, we talked about the adult population having to do their renewals as back in 2023. Now it is the time for children to have their renewals, child renewals to begin again. So last month in July, it was technically back to normal for children enrolled in Medicaid as well. And so the first notices went out in May 2025. Just saying, hey, your child is up for renewal. This is the information that we need. You need to submit it by July 31st. There were 31 days in July. Okay, great. So those first notices went out, and we don't have any data from how that first month went yet. We had a meeting with the cabinet last week, and so they had just finished running the report, and overall they had an 84% ex parte rate, that passive renewal rate. So for the month of July, everyone that was due for renewal, adults and children, 84% of them did not have to do anything. They did not have to submit any paperwork, any additional documents. The information in the system was enough that the state was able to just say, oh, great, their information is the same, they're eligible for another 12 months. That other 16%, they had to submit something. And we know that around 8,000 folks lost coverage at the end of July. We don't know how many of them submitted paperwork yet. We don't know how many of them were children yet. We'll have that information next week. But again, that's why it's so important. 8,000 people lost their coverage at the end of July. And so it's really, really important to make sure that all of your contact information is up to date and connect. Again, connectors can help with that if you need help or if you have clients who need help with that. Make sure contact information is up to date. You can do that. You can log into Connect yourself. Clients can log into Connect themselves. Or if they need help, they can, having trouble doing that, you can call the Connect hotline. You can reach out to a connector for help doing that. You can also use the Connector on Demand system, which is now live, and it lets you submit your information. Um, it lets you submit your information ahead of time, and then a connector will reach out to you directly. They may or may not be in your specific county, but they can reach out to you directly and provide that assistance versus like you having to call and leave a voicemail or something like that. And you can also, if you're working with any providers, if you're working with clients who are going to providers' offices, they can also ask their doctor to check the KY HealthNet, and it will list the renewal date in the system in KY HealthNet. So it's also super important to check your mail and or check and follow up if you receive mail for a client who's getting something from CHFS. It's really, really important to act on that notice because it could be about the renewal, and we don't want to see them lose coverage because they did not get that notice or they didn't fill out the paperwork. So we also have this great one pager that we've updated, and it's available in English and Spanish. We're working on translating it into 5 other languages. But right now it's linked here. And a really important reminder, which I'll talk here, is that the income limits for children, the income eligibility limits for children is actually much, 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 much higher than it is for adults. So a lot of times adults will look at the income limit for their household size, and they will think that, oh, I make over that, and so the whole family is not eligible, but that's not the case. The limit, so in a good example, let's look at my handy dandy chart that I included, but like for a household of 4, the income limit for the adult in the household, let's assume a 2-parent household, 2 children, the income limit for adults is $44,376. But the income limit for children under 19 is $70,000. So if for a household of the four-person household, 2 parents, let's say they make $50,000, the parents are not eligible for Medicaid. They'd likely be eligible for a pretty affordable subsidized plan, ACA marketplace plan, but they wouldn't be eligible for Medicaid, but their children definitely would be. $50,000, they would definitely be under that $70,000 number. And so when in doubt, just fill it out. Do not assume that you're not eligible. Do not do the math yourself. Just submit an application and let the state make the determination for you. And kids are granted 12 months of continuous eligibility. So once they're approved, they are set all year. So even if your household income otherwise changes or fluctuates, the kids are guaranteed coverage for under Medicaid for 12 months, and there will be no interruptions to that. So, and there's again, fill it out, share this information. The state also put together a great packet of information that's linked here, and it also includes the federal poverty limits chart if you want more household size examples. Okay, and just a reminder, so currently about 94% of all eligible kids in Kentucky are currently enrolled in Medicaid. And that's about 46% of Kentucky children are covered, and 46% are covered, and that's 94% of the eligible kids that are covered. So there's still about 6% out there who are eligible but not enrolled. So, if you have patients, families, clients, neighbors who that are uninsured, it's important to connect them to connectors, share this information so that they know that there are resources available for them. Around 50% of Kentucky children under kinship care do receive Medicaid. Medicaid also plays a big part in schools being able to provide health services and health staff like nurses and therapists and psychologists. So this a cut to Medicaid is going to be a lot. The ripples of that are going to absolutely show throughout our community, including in our schools. Um, and yes, gaps in coverage lead to more emergency room visits, missed school days, higher costs for families and providers. And there's a really interesting study that showed that that children are more likely to be covered and enrolled and go to a doctor or provider when their parents are covered. So even if if you're working with clients who are not insured themselves, a lot of times I also have clients who, like I don't want insurance, but I want to make sure my kids have it. So any resources that you can do to connect them to health coverage, it will make a difference for the whole family. Um, and so just again, for children, making sure it's so important because it's foundational for stability, housing, security, opportunity, being able to have stable health so that you're stable enough to go to work, so that you're able to access the treatment and care that you need so that you're able to be healthy enough to show up as a parent, to show up in your community, to show up for work, all of those things. It's so, so important. Children and youth in unstable housing situations often face higher risk of chronic illnesses, often because they don't have that established provider relationship. And so, sometimes there are chronic issues that are missed early on because there is not that established relationship that then can become a much bigger illness later on as they're growing up. Gaps in care can absolutely escalate into crises. Thinking about me with pneumonia, I ended up having to go to the hospital or my rent that several months because I would have had to spread it out. So again, super important. All children in low income households, I mean, all of them would qualify for Medicaid regardless of housing. Your housing status does not prevent you from being eligible for Medicaid or marketplace coverage. Youth aging out of foster care are eligible for Medicaid up to age 26, and there is not an income test required. And Medicaid does cover preventative care, mental health services, prescriptions, dental vision, and transportation to appointments. The dental vision for kids is actually much better than it is for the adult population, but it's still available for adults now too. And that was a change from 2023. So still new, but it's very important. Medicaid does cover all of those benefits. A lot of times, youth and caseworkers just don't know about extended foster care coverage. A lot of folks think that that they age out at 18 or 21 and then they're no longer eligible. Once they age out, they're still able to be enrolled. And that goes also for kids who are leaving their household. If they were on their parents' case, they're eligible up until 19, and then at 19, they lose eligibility under their parents. But if they're working, if they're in school, they can still be eligible on their own as their own adult case. Frequent address changes can definitely lead to loss renewal notices and coverage lapses. Again, super important to keep those addresses up to date or find a place where you can get a stable place where you can get those notices so that you don't lose your coverage. If you need help trying to find, one of the things that folks can do is helping people find a place where they can just physically have those notices sent to. You can have your mailing and housing addresses different in Connect. You're residing here, but your mailing address is here. And so that's a really important thing to do. And limited internet phone access makes enrollment and recertification harder. We've talked about that. If they're, you know, if you're working with clients, making sure to ask about coverage, like do folks have Medicaid? Are they enrolled in something? If you're working in the community, asking about that and making sure to refer them to local connectors because connectors, it's not on you individually to solve all of the problems, but you can refer them to those connectors who can help navigate them through that process. They're also able, you can also share information about foster care, Medicaid coverage, and youth programs, and partner with schools, shelters, foster care advocates, just to help keep enrollment active. Because again, we don't want to see folks lose their coverage. Um, all right, and then so with HR1, like I said, we walked through that timeline. We know we're we've got about a year before some of the biggest impacts in Medicaid kick in, just a couple months before the biggest impacts in ACA kick in. We're doing a lot of advocacy around harm mitigation. It starts now. The rules are already developed. The big guidelines are already developed, but there's certainly a lot more work that will need to be done as the rules are being developed, the guidelines about how to actually implement it into the system. There's the policy, and then there's the implementation of it into the system and the way that the process actually works. So if you want to get involved, again, you can participate in public comment periods. There will be meetings and opportunities to participate in system design meetings, system testing, other public comments. And then state legislators this year will certainly be grappling with federal funding cuts and changes to eligibility that will absolutely increase Kentucky's uninsurance rate, reduce provider reimbursement, and impact the workforce. So if you're available and interested, you can attend committee meetings. You can schedule one-on-one in meetings with your local legislators. You can film videos. You can caravan to the Capitol. There are lots of different ways to get involved and make sure to talk to your legislators and share just the impact that you're seeing with your clients, within your community, with your family, with your friends. This is going to have a big impact, and those impacts are going to ripple through our communities. So making sure you stay engaged and just share your experience. I work with a client and this is their story. They don't feel comfortable telling their story, but let me tell you what I'm seeing. So that's really powerful, and it helps make sure that the stories of the people who are impacted are present and are being shared and not dismissed, as the budget discussions start. Okay. No, for whatever reason, my computer just my slides are not. What just happened? Um. Well, sorry, y'all. I'm experiencing some technical difficulties. Oh, there it goes. Boy, did that just speed up so fast. Hold on, sorry.
Well, I'm not sure what happened. Looks like we lost her. Let me see if we can get her back. Okay, I'm not having any luck bringing her back in. I don't know if she realizes that she's been knocked out. Well, I apologize to everybody for this. We'll give a couple more minutes and see if she's able to get back in, and if not, we'll unfortunately have to end this session early.
I just hopped on. Can you? Okay. Hi. Sorry about that. My internet totally just completely went out.
Okay, we are good to go.
I'm so sorry about that.
Yeah,
I
technology's wonderful until it's not.
I know. My internet, just decided right now it was going on a lunch break. It was done. But I switched to my hotspot on my phone. So
Okay.
hopefully that.
Okay.
So sorry.
Okay. Turning it back over to you.
Okay, give me just a second to get back into my place. This is again, what if this happened during an application? Internet can be so great and also unreliable, even at the best of times. So, all right, let's jump back in here and share my screen and then hop into the PowerPoint. And I am going to kind of um, talk a little less, but still get into this. Um, there we go. Okay, sharing screen. Zoom forward. Okay. So, what I was saying about harm mitigation, there are lots of opportunities for advocacy between now and the implementation of HR1. It's super important to get involved and make sure that we're elevating the stories of people with lived experience and, the things that we're seeing in our communities. So, to pivot from there, let's talk about Connect resources and just finding community resources. So Connect resources, again, it's part of the Connect branding, which I appreciate because it really does make Connect a one-stop shop where you can apply for benefits. You can apply for all of the programs that you're eligible for. And also find community resources and referrals to things that folks need to live a healthy life. And so Connect Resources allows residents to browse community programs and services available and help with needs like food insecurity, housing concerns, employment, and newly transportation. There's been a collaboration between the Department of Transportation and DMS and Connect to integrate all of the non-emergency medical transportation brokers into Connect Resources so that if you need a ride to a doctor's office, if you need a ride to a medical appointment, you can find your broker. You can find your broker, contact them through Connect Resources. So that's really great. It's a directory of program services and supports throughout the Commonwealth of Kentucky, and it's built in partnership with United Way. So United Way helps staff it and make sure that any referrals that are made through Connect Resources are able to be closed. The people who request that referral, request that need, they're actually able to get connected to that service that they're requesting. So that's really great. Um, it's supposed to help reduce just barriers to finding help. Everything is in one place, and so you're able to find all of the resources that you need in one place, that one-stop shop. It's also a closed loop referral process. So again, once a community person or an individual opens a request for a referral for a service, a United Way makes sure that they go back through and make sure that all of those loops have been closed. So if a organization hasn't reached back out to the individual or hasn't responded to that referral, United Way calls that organization, reaches out to them, and helps make that connection. They recently integrated a social determinants of health assessment, both into Connect Resources and into the Medicaid application. And so they're able to collect information on all of those social determinants of health, like housing insecurity, food insecurity, needing job, transportation, things like that, so that they're able to highlight, oh, here are areas where you might need resources, and then as you're working with a connector or you're working with someone, they can easily, they do a red, yellow, green system. So things that are a critical need are red, yellow, like they need some support, green, they're all good to go. And so folks helping individuals are able to very quickly um, now I'm nervous about my computer. They're able to very quickly say, oh, here's the red stuff. Here, let's make those connections right now. Here's some yellow resources, and kind of go from there. This is the process of a referral. A community partner works with a resident, and again, it's sort of what we've already talked about, so I don't want to spend a lot of time here, but you can study this in the slides later if you'd like to. Again, all of the resources are available on Connect Resources. And this is that red, yellow, green that I was talking about. It looks through risk factors, community involvement, life skills, mental health, mobility, disabilities, and employment, a whole series of things. And so then they're able to share that information between both Connect Resources and Connect. And they're also working on integrating it into the Kentucky Health Information Exchange. So providers are also able to see that and provide an additional level of assistance as well. So, and this is actually a little old. I just got an update that we're closer to almost 9,500 organizations listed in Connect Resources right now. But there are around 20,000 resources listed in Connect. There are more in Jefferson County, of course, because of it being Jefferson County, being a hub, but there are certainly a lot more organizations that could still be onboarded and work with Connect Resources to be listed there. And if you're interested in that, I have information that I'd be happy to pass on along. And so this is all of the people who are involved: connectors, United Way, community partners, DCBS staff, providers, medical providers, state agencies, all of us working together to help make sure that consumers are able to get connected to the resources that they need. This is what it looks like. Here's all of the different ways to search by category and subcategory, browse your results, and you can search for specific things. So again, if you are working with a client and they need help, they need connection to some resources, all of that stuff lives in Connect Resources. And then for KVH, we have our own website, kyloop.org, and we have a database of one-page explainers. So that one pager about Medicaid renewals that was on that first slide about it, that lives there. We have KY Loop, and it is, you don't have to log in anymore. But we do have a database of resources, and we have put together little helpful one-pagers about all of our big programs, SNAP, the Medicaid renewals, Medicaid, the work reporting requirements for SNAP and coming with Medicaid. And we're continuously building those out, and they live here, but we also gather resources from all of our partners, from statewide resources, that are more targeted to community professionals. So resources that help the folks helping folks understand all of the different program changes, eligibility, the resources that are available out there. And so you can check out these explainers on KY Loop. And we, again, everything is eligible. Everything is available in English and Spanish right now, but we are working on building out an additional 5 languages or so, just so that we can continue to spread the word and make it more accessible to more folks. But if you have specific requests or specific information that would be helpful, please reach out. We are always taking suggestions, and we love to build a one-pager just to help make it more understandable and accessible and easily shareable for you and your job. And so with all of the information that I've shared that is in this slide, in the slide deck, I always like to end with just a reminder that it's tough out here, that there's a lot of news, there's a lot of, a lot of fear in communities, and just working with clients can be very rewarding. It is genuinely one of the best parts of my job, but it's also the hardest part sometimes. And I think folks who are working with especially vulnerable populations, it's really, really important to not only take care of your clients, but especially to take care of yourself. And so for your clients, if they need help, if they need some mental health support, MHAKY is a great resource. The crisis text line is available. 988 is available. but also for you as the people on the front lines who are helping people who are just also living in this environment where the news is a lot and there's a lot happening all around us. You can definitely always reach out to any of these numbers. If you want any training, MHAKY does a lot of great mental health training, first mental health first aid training specifically. They're an incredible resource, and just make sure you're taking care of yourselves and prioritize that too, because you can't give from an empty cup. And we, especially with everything going on, it's really important to protect ourselves from burning out. So with that, again, if you're interested in joining Medicaid Defense or ACA Defense, again, it's going to be rebranded probably at the end of this month as Keep Kentucky Covered Coalition. So if you're interested, feel free to click that link or join. You can get to the survey with that QR code. Or reach out to my colleague Morgan. She helps run these meetings. She's incredible. And if you have any questions or you want more legislative updates, you want key updates about what's going on. If you have a story that you'd like to share, if you've worked either personally, you want to share your story, or you've worked with a client who you think has a really good story that you'd like to elevate. We also help with story banking. And that can either be with like writing a testimony, writing an op-ed, taking a video and taking it to a legislator, recording a like more formal stylized video of someone telling their story. We help with all of that. So if you're interested, please reach out to us. And then if you just have any ideas on actions to take, any ways that you want to get involved, things where you feel moved that you would like to participate in a way, again, reach out to us. So yeah, and together we can protect Medicaid, we can protect our healthcare, and we can make sure that Kentuckians get to stay protected. I mean, they should be. We're all in this together, and we want to do everything we can to make sure that Kentuckians stay covered. So, and with that, with 2 minutes left, sorry to take up more of that time, but I feel like we got a chance to go over a lot of really great information. If you have any questions, if you want to connect, please don't hesitate to reach out to me. That's my email. I'm always happy for emails. I'm always happy to talk to people about any of this. And I am not afraid. If I don't know the answer, I will happily go find the answer or find someone that I can connect you with who has the answer, or we can talk about that more clearly. So with that, I am done. I don't have anything else, but if there's a minute or two for questions, if anybody has anything that they'd like to throw out there.
Priscilla, thank you so much. This is just a ton of information. And I know it's going to take us a while to kind of sort it through our brains and make sense out of some of it. But it's critical information for the clients that we serve. Will you send me the slides and then I can distribute those to everybody that was in attendance today?
Yes, absolutely. And
So much.
not to put anybody, I'm going to stop sharing my screen, hopefully, if I know how to do that. But yeah, it's a lot of information. It's a very chock full 90 minutes, minus the few minutes where my internet went out. But if you have questions after the fact, follow any of the links. They're all live and active, but you can also just email me and reach out to me, and I'm happy to answer any questions that come up.
Let's see, we've got
Oh,
some
yeah.
here.
Oh, thank
One of the
you.
best benefits presentations I've ever attended. Good to hear that. Very, very
Yeah,
good. Put that on your survey.
I will. I'm gonna text my boss that immediately.
Yeah. Okay. All right. Well, I'm going to go ahead and close this out. Priscilla, again, thank you so much. You're such a friend and an ally to who we are and what we do. And I'm glad you're in our corner. And I hope that you get some responses on the Medicaid Defense Coalition, whatever you decide to call it. I hope that some people will decide to be a part of that. So, again, thank you so much, and get me the slides and I'll make sure that everybody gets a copy.
Perfect. Thank you so much. Thank you for letting me join. I'm always happy to be here, and I'm so glad to have shared this time with you guys. Thank
All
you.
right. Everybody
All
have a
right.
good day.
You too. Bye.
Bye-bye.